Hi everyone, this is Liz and I'll be giving your lecture today on patients with special challenges and with an extra focus on patients with technological dependence. So we're going to talk about a lot of different unique pieces of medical equipment that you'll encounter working EMS, and some of these are not very common, some more common than others, but they're all things that you need to be familiar with, because if you do encounter them in the field, you really need to understand what you're looking at and why the patient has that piece of equipment so that you can properly assess the patient and provide them with treatment. So we'll start off by talking about some of the special airway and respiratory devices that you'll encounter. So first off, oxygen, which this one's pretty straightforward, and you're going to be really familiar with the standard application of oxygen that you're used to in the ambulance, and in your truck you're going to have an oxygen cylinder that looks similar to this one here. You're going to have these big cylinders. Usually there's one or two of them in the truck to supply the truck's oxygen. And then there's a little one or multiple little tanks that you can carry with you into homes. But there's a few more ways that oxygen can be administered to patients in the home setting. So you need to be familiar with those because patients might call you, one, because they might have a problem with the oxygen, either a concentrator, a cylinder, or their liquid oxygen. They might have an issue with that device. And two, they might also just call you because of worsening of a condition they have that requires oxygen. So you might be called there to essentially to troubleshoot their oxygen or just treat a patient who's on oxygen. And sometimes patients can also just run out of oxygen, and that might also be a reason that you might be called. So oxygen cylinders, let's go back to this picture. Remember, this is the oxygen cylinder or the compressed air tank. And it's just compressed oxygen, and its administration is adjusted by a flow meter. And typically in the home setting, patients will most commonly just be on the nasal cannula. And remember, some patients are on this 24/7. Some patients only need it with exertion. Some patients only need oxygen while sleeping. So that can be pretty variable. There's another device called an oxygen concentrator, and this one's pretty common. I saw this a lot, and it's a smaller device. It's portable. Patients can take this to the grocery store, and you'll notice this if you start paying attention when you see people carrying oxygen tanks around or devices. You'll see these out in the community, and it extracts oxygen from the ambient environment and supplies that to the patient. Usually these devices are only capable of delivering flow up to around 6 liters per minute. And again, these patients will be on a nasal cannula. And then the third one is liquid oxygen. This one's interesting. It's not, I personally did not encounter this as much, but it's certainly still in use in the community. And this is when atmospheric oxygen is cooled to 183 degrees Celsius, and then it's stored under pressure. And the upside to this is that you can have a pretty small container. It's similar to the size of a thermos and the structure of a thermos. So the patient can keep a large liquid oxygen storage unit in their home, and then they can refill their portable units to take with them either around the house or out while they're running errands. And patients, the benefit would be that they can refill it and they have good mobility because they can always take that tank with them. So you'll probably see most of these, if at least the cylinders and the concentrators. And, you might, it's important when you go to a home, and whatever the complaint is, you need to keep in mind what type of oxygen delivery device they're using, and keep in mind that it might not be functioning correctly. Sometimes you might find that they're complaining of shortness of breath, and if you look at the oxygen tank and you look at the flow meter, it might be empty. So that's an important clue. And you can also find other issues where there's faulty tubing. The tubing might be kinked, or if it's a concentrator, maybe it's not plugged in. Maybe there's some type of power failure on the concentrator. a leak in the tank. There's a lot of things that could potentially go wrong with these devices. But I will say, don't lean heavily on if a patient's short of breath and they're like, oh, something's wrong with my oxygen. Don't lean on that. Remember to assess your patient because they might have a worsening condition that's causing them to have an increased oxygen demand, and there might be nothing wrong with their equipment. So don't get distracted by trying to mess with their equipment too much. My general rule is if there's a patient on home oxygen and they're having some type of respiratory distress or respiratory symptoms, my general rule was just to go ahead and take them off their home oxygen and put them on your tank. If you're not sure how their stuff works, and you're not sure if it's functioning correctly, you do know how your oxygen works. So go ahead and just get them on your tank, and then if you need to later, you can troubleshoot their oxygen tank. If you do find out that there's a leak in their oxygen tank, go ahead and turn that off, especially these compressed cylinders because oxygen is flammable. At that point, you can call the fire department, open some windows, make sure there's no open flames, they're not smoking. You'd be surprised how many patients smoke that are still on oxygen. So just remember that oxygen is flammable. I had one patient encounter where we were called to a pediatric patient who was actually had a tracheostomy and was oxygen dependent. And this patient was on a road trip. His parents had taken him on a road trip, and they had called us from the side of the road because their car had broken down. And they had even packed extra oxygen tanks and thought they had prepared for anything, but this delay in the trip really caused a problem. So they were out of portable oxygen, and for some patients, that's critical. People can be very dependent on this oxygen. And unfortunately, you can't just give away your oxygen tanks. So we ended up having to transport that patient to the hospital. And from there, the hospital was able to arrange for them to take additional tanks with them. But, that's just a story to give you an idea of how random some of these issues can be with oxygen-dependent patients. Something else you will probably encounter is something called an apnea monitor. And an apnea monitor, I guess let's start with what apnea is. Apnea is, by definition, that just the temporary cessation of breathing. So little infants is where you're going to see these apnea monitors, and quite often it's premature infants who get sent home with the apnea monitor. These monitors, they monitor the breathing of the patient, and then they can also monitor heart rate. And if there's abnormalities in the breathing, the heart rate, these apnea monitors will get triggered and let out, the noise can be different, but say a beeping noise. And the beep can progressively change the longer or get louder or more frequent, the longer the alert sounds in case the parent's not in the room to immediately hear the alarm. And as an EMT, what can happen is you can be called for an apnea monitor that was alerting, and you can show up, and the infant will look normal, be breathing normally, and have a reassuring exam. And then you have to figure out what to do. What did the alarm mean? What should I do? And then the other option is, you show up and the child is in respiratory distress and needs intervention. I think it's important to remember that if the apnea monitor has alerted, the patient is going to require transport. Even if you do your exam and it's like, well, this little kiddo looks fine, they're breathing fine, their heart rate is fine, their vitals are fine, but they need to be seen at the hospital to figure out why they went apneic or what happened and be evaluated. So you would transport these patients. And then if you get called for an apnea monitor and you show up on scene, remember to stick to your basics and evaluate the patient's airway and breathing and circulation because they might need an intervention. And there's nothing particularly unique about the way you'll intervene. You still need to support their respiratory status, give positive pressure ventilation if they need it, provide supplementary oxygen if they need it, and make sure that their circulation is adequate. you don't want to really waste time or try to troubleshoot the apnea monitor or think, why did it go off if there's no obvious reason, or try to say, oh, it's not working. Just go ahead and transport these patients for evaluation. And one other thing to note, the reasons, why do these kids have the apnea monitors? So I mentioned that a lot of times it's premature infants, and what can happen is if their brain and their spinal cord is not well developed due to prematurity, sometimes their neurological system cannot maintain constant breathing, the normal respiratory drive, and prematurity alone can trigger issues with respiration and their heart rate. And then, some other more acute things can cause these same issues. Things that you have learned or will learn about, things like, acute brain injury. These patients might have lung developmental problems, or if they have an infection, that can also cause an apnea alarm to alert. All right, let's talk about trach tubes, tracheostomy tubes. So a tracheostomy is an airway, and it's considered a secure airway, and it is a tube that passes through the neck, through the skin, through the neck, and straight into the trachea. And these are surgical airways. And it's an alternate route for air to get into the trachea and into the lungs, and by bypassing the upper airway. And some of these patients might also be on a ventilator, so the ventilator might be attached to the tracheostomy to actually provide the respirations, or this tracheostomy can also just be open to room air, and some of these patients don't need supplemental oxygen, they don't need a ventilator, they just need the tracheostomy to breathe through. These airways can be pretty intimidating, and some of their emergencies can be kind of scary because these can often be quite precarious patients to start with. So it's important you understand how these work and what you can do as an EMT, because some of your actions can really be life-saving here. I do want to talk a little bit about, if you're called to someone with a tracheostomy tube and they're having difficulties breathing through that tube, it's usually one of two things. Usually it's either the tube has become occluded, like blocked, or it has become dislodged. And when it's blocked, it can be blocked by things like mucus. These patients can produce a lot of respiratory secretions, and sometimes a mucus plug can actually block that hole. And then I'll show you in a second what this looks like inside the patient's trachea, but that inner cannula can also become dislodged or moved and cause issues with respiration. So these tubes can be semi-temporary. Some patients have these for only months at a time, or they can be permanent, and some patients will have these tracheostomies for the rest of their lives. The reasons patients get these, highly variable. Anything that disrupts the upper airway, a traumatic injury, so if they have an example would be blunt or penetrating trauma to the larynx, the epiglottis, anywhere in the upper airway that prevents adequate movement of air through the nose and the mouth and into the trachea. Additionally, spinal cord injuries that prevent the patient from controlling their upper airway can also be a cause for needing a tracheostomy. A lot of medical conditions can lead to these. If a patient has weakened respiratory muscles, then those patients will often need to also be on a ventilator, but they're often, it's not practical for a patient to have an ET tube in their mouth and down their throat for long term. So these patients are given a tracheostomy so they can be sustained by a ventilator for the long term. Some people have congenital deformities that make it just impossible to respirate in the normal way through the mouth and the nose and into the trachea. Some airway diseases, some tumors can block the airway. After patients have strokes, they can have issues stimulating the respiratory system, controlling their airway. Same idea for brain damage as is the stroke. And if a patient is comatose, they may also need a tracheostomy tube. So if you look, here's the tracheostomy tubes here on the right. If it's a pediatric patient, especially a young infant, they'll often have a single lumen, which means there's just one solo tube. As the airway of the patient gets bigger, so older children and adults, you end up having a double lumen. The double lumen just means that you have the outer lumen here. This one keeps the opening open, or the stoma open, and then the inner lumen here that goes inside of that, and that's a double lumen. And then this end here is where the BVM attaches, and this here is the obturator. And the obturator is a device that goes inside of the inner lumen temporarily, and this little end here creates a smooth surface so that when you insert the tracheostomy tube into the stoma, into the patient, it provides a smooth surface so it can be inserted. And then this is removed. This does not stay inside the tube. Patients who are at home and have tracheostomy tubes, they'll have spare, or they should have spare equipment at home, because it can be life or death for patients to have the proper size tube and backup parts. So I mentioned briefly earlier the emergencies, but we'll work through them a little bit here. So one that is very common is blockage by mucus. And when that happens, a lot of times you can actually hear the kind of junky sound and like the air trying to squeeze through the mucus as they're breathing. You could also have obstruction from bleeding. So if for whatever reason their site of their stoma becomes injured, cut, has any type of trauma, or maybe it's infected, you can have bleeding around the site, and that can occlude the airway as well. And I keep referencing the stoma. I probably should have said. So the stoma is the opening. The tracheostomy is the actual device, and the stoma is the opening in which it's placed. Again, these patients can have infection that can cause a lot of secretions. And you can have something called an air leak. And what this is, some of these tubes are what's called cuffed, which means that they have a balloon around, at the tube that inflates. And it's kind of like an ET tube. So you put the tracheostomy in and you inflate a tube, and it holds the tracheostomy in place, and it prevents air from flowing outside of it. If the patient's supposed to have that cuff on there and it's ruptured, it doesn't hold air, then the air can move around the tracheostomy, and it's not directed where it's supposed to go. So if a patient is trying to breathe in through the tracheostomy site, the balloon is supposed to prevent that air from going up and out the mouth. So if the patient's on a ventilator, for example, and you have pressure pushing the air in, if you have a cuff leak, the air isn't being directed down into the lungs where it's supposed to go. It can also escape through the nose and mouth, and that's called an air leak. And then lastly, you can have dislodgement of the actual tracheostomy tube or the inner cannula if it's double lumen. And you can also have a foreign body occlusion, which typically is going to be mucus, but anything getting into that tube can be problematic. If you do find, there are some things you can do. So if you do find that there's mucus within the tracheostomy tube, this is something that quite often you can fix. What you can do is take about 1 milliliter of normal saline and just inject it right into where the mucus plug is. And then you take your soft tip suction catheter, which is usually about half the size of the tube, and you can actually suction the mucus out of the tube. You want to keep this as sterile as a procedure as you can, because remember, this is going into their trachea and into their lungs, so you don't want to contaminate their airway. You can measure the catheter, the suction catheter, by comparing it to the length of the obturator. It's just so you remember, this is the obturator. It's a guiding tool that goes inside. That's the obturator. And that's a good way to go ahead and measure the length of the catheter. So when you insert it, you know not to insert it further than the length of the obturator. If you don't have that to compare it, then you can just insert the suction catheter until you meet very light resistance. And then when you apply suction, you just go ahead and withdraw the suction as you're suctioning and rotate it to try to get the mucus plug out. It's 5-second approximately suction for a pediatric patient, and then 10 to 15 seconds for an adult. This is often going to trigger the cough reflex in the patient, which is good. You want them to go ahead and try to cough up any secretions they can, but just be forewarned that oftentimes the patient will cough while you're trying to suction. This is one of the scarier complications, I feel like, if your tube becomes dislodged. If the tube is partially dislodged and they can't move air, you might have to remove the tracheostomy tube. And I don't want you to take this lightly. You should never be removing a trach unless it's truly dislodged or you have no other choice. You can very easily lose an airway in these patients, and those trachs were placed for a reason. So don't take it lightly, and just don't be too eager to remove the trach, because you can really get yourself in a very tight spot. And then replacing the trach is not as easy as it may seem. Usually these patients have a care provider with them. That's very common. If they don't, a lot of times they have family members that are very familiar with the care of the trach. Sometimes you can get into a tight spot when people shortly after discharge home, when they're not as familiar with their trach, and they might rely on you a little more heavily in those cases. If you do need to remove the tracheostomy tube, you have to remember that first you need to see if there's a cuff to deflate. And this looks just like the way that you would deflate an ET tube cuff. You look for something that looks similar to that and go ahead and deflate the cuff. If they have someone there who's familiar with it and is trained in the trach, go ahead and have them remove it. They're going to know more about it than you will. And then here's the tricky part. So once the trach is out, you need to ventilate the patient. They're not going to be able, they're on the trach for a reason. So odds are they're not going to be able to just breathe on their own without a problem. So the first step is to go ahead and cover the stoma, and remember that's the opening in the neck, and then ventilate with your bag valve mask through the mouth and the nose. So just like you would a normal patient. But the tricky part is some of these patients don't have normal airway anatomy. Some of these patients, their nose and their mouth no longer connects to their trachea. So if you go to bag the patient and you meet a lot of resistance and they don't have chest rise and chest fall and there's no breath sounds, it's probably because there's an obstruction. And this could be an anatomical obstruction that you can't fix. So in that case, if that doesn't work, the next step is to say, okay, now I have to cover the mouth and the nose, and then you're going to ventilate through the stoma. And you do that by placing the face mask directly over the stoma. So it can be, you just have to understand the possibilities here in the patient's anatomy to try to troubleshoot this. So for CPAP and BiPAP, you're familiar with CPAP because it's a tool and a therapy that we use in EMS. BiPAP is a similar concept, but both of these you can potentially see in a patient's home, and patients may use these on a regular basis. Typically, they don't really keep them at home for emergency use. It's more of a chronic use for chronic medical issues. So the CPAP, remember, is the continuous positive pressure, positive airway pressure, and the pressure is continuous both during inspiration and expiration. So every time they breathe in and breathe out, it's the same amount of pressure, trying to help and keep the smaller airways open. The BiPAP is bi-level airway pressure. So for the BiPAP, the patient actually receives higher pressure when they inhale and then lower when they exhale. And that actually makes it a little bit easier to exhale and still accomplishes the goal of helping to keep the smaller airways open when they're exhaling and decreasing the work of breathing. Remember, the main concept for both of these is keeping the bronchioles open, smaller airways, decreasing the work of breathing, and improving oxygenation. And the CPAP and the BiPAP both do that through the back pressure I was talking about, the pressure it puts in the airway during exhalation. You'll see this mainly in COPD and patients with sleep apnea. Sometimes the patients with sleep apnea will obviously only wear it at night when they would experience the sleep apnea to help keep their airway open. And COPD patients can be variable. A lot of times these patients will just wear it at night, and sometimes they might need to wear it a few hours during the day as well. And again, that's for chronic issues. Emergencies with the actual equipment, so the actual CPAP and BiPAP, are pretty rare. It's pretty unusual that you would be called to a patient and the problem would actually be the equipment. More often, what's going to happen is these patients are going to be having some type of exacerbation of their disease state. So if that's some type of respiratory disease like COPD, usually they're having worsening of that condition, and they might talk about their CPAP or BiPAP, or they might be using it during the emergency, but the issue isn't necessarily the actual equipment. So just remember to really ask what's going on with these patients, do a good assessment, and really get back to your airway basics to see what you need to do to help treat that patient. So home ventilators, so we talked about the tracheostomy, and quite often with the tracheostomy will come a home ventilator. And, patients on these ventilators can range in age from very, very young pediatric, neonatal patients to older adults. And the ventilator assists with the mechanics of breathing. So in this little kiddo here, it's attached to his tracheostomy, and then all these tubes, and they can be pretty intimidating looking, go to the ventilator here. And the ventilator has a few different controls, one of which being the rate of the breathing. So oftentimes they do actually control the rate. The tidal volume, so the amount of air reaching the lungs with each breath, and then the amount of oxygen being given with each breath. Similar to you saying, I want to do 3 liters or 6 liters. The concentration of oxygen can also be controlled with the ventilator. So these patients are going to be patients who can't breathe adequately on their own. And, like I mentioned earlier in the lecture, that can be due to structural defects in the thorax or the lungs. It can be due to various injuries such as strokes, brain injuries, also long-term lung diseases. All sorts of things can cause patients to be on ventilators. I think an important thing to remember when approaching a patient on a ventilator is that you really have to remember that you have the patient and the ventilator, and not get tunnel vision and focus in and say, because this ventilator is alarming, it must be a problem with the ventilator, and trying to fix the ventilator and figure out what's wrong with the ventilator. Because a lot of times it's because the patient has gotten sick. And sometimes these ventilators, if you're called for, maybe the complaint is our ventilator, an alarm is going off, we don't know what's going on. And a lot of times the alarms are triggered because the patient is having some type of event that is essentially alarming the machine and saying something is not right with the pressure, something's not right with the tidal volume, or something is wrong with the oxygenation. So there's 3 main alarms that you might encounter on a ventilator, and this is by no means meant to be a comprehensive lesson on how to troubleshoot a ventilator or how to set up a ventilator. But I think that just understanding these basic concepts, you'll understand what it says if you see something that says high pressure or low pressure or low FiO2. Just understanding what that might mean, and that will help you figure out what's going on with your patient. So you might encounter an alarm that says high pressure. And basically what the ventilator is saying is in order to deliver the breath that it wants to deliver, it is sensing that it has to push too much pressure into the lungs to get that volume. And that often happens because of some type of obstruction or resistance or decreased compliance in the lung. So the ventilator is having to push really hard to get the right amount of breath in. Some really simple things that can be things like mucus plugs in the tubing, similar to the tracheostomy. If there's a mucus plug in the tracheostomy and the ventilator is pushing against that, that can cause increase in high pressure. If the ventilator circuit, and the circuit just means the airway tubing of the ventilator, if that's kinked, then that could create high pressure. Similarly, improper movement of the tube, bronchospasm. So that's a really good example of an issue with the patient, not the ventilator. But if they're having bronchospasm and their airways clamped down, then they can have high pressures. Similarly, decreased lung compliance, that happens. Remember, the decreased lung compliance just means that the lungs and the airway are stiffer and don't inflate as easily. So a pneumothorax is an example. You have essentially a collapsed lung, and that can cause high pressure in the airway. Pneumonia, if someone has an infection, that can cause decreased lung compliance. Pulmonary edema is a similar concept, and then alveolar collapse as well. The next alarm you might see is low pressure. And what this is saying is the tidal volume, which is the amount of air delivered to the lung with each breath, is falling below the volume that it should be. And typically what this means is there is a problem with the machine or the equipment. So if the tubing isn't connected properly, the machine's trying to push in a set amount of air, and that air is not making it to the patient. And this can also happen if there's a leak in the cuff of the tracheostomy tube, like we talked about earlier, where you have that inflated balloon. If that deflates, then that air is not going to go where it's supposed to go, and the patient will not get adequate tidal volume. And then lastly is low FiO2. And FiO2 is just the fraction of inspired oxygen, which is essentially saying that the oxygen source to the ventilator is depleted. And it might be something wrong with the tank, something wrong with the tubing coming from the tank to the ventilator, and the machine is sensing that the ventilator is sensing it's not getting enough oxygen to give to the patient. Ventilators are incredibly complicated, so just keep in mind these basic concepts, and that'll help you troubleshoot them. But don't get too caught up in the details of the ventilator. I remember responding to my first few calls where I had a patient on a vent, and I was intimidated. And I think it's easy to be intimidated because it's complicated equipment. These can be some pretty sick patients. But if you just remember that you have solid base knowledge and all of the concepts you've learned still apply to these patients. So when you're evaluating these patients and you're having these alarms go off, or maybe their oxygen saturation is dipping, remember you still can assess your airway, breathing, circulation, and you can still listen to see what it sounds like. Are you hearing breath sounds? You can still look at the tidal volume, look at the chest rise and the chest fall. Is it adequate? Is it symmetrical? You can still listen to their lungs. Their breathing is often noisier on the ventilator, so you might hear kind of noisy breath sounds, but you can still hear wheezing. You can still tell, are there absent breath sounds on the right, or are there absent breath sounds on the left? There's all kinds of clues you can still get from these physical exams. So, when you first approach this, just remember that it could be the ventilator. It could also be a change in the patient condition. So what you can do is, if you believe you're having issues with a ventilator, you can go ahead and detach the ventilator from the tracheostomy and then manually bag the patient with a BVM. And if the ventilations go in super easily then you might be like, okay, this is an issue with the ventilator because this patient is ventilating well, their condition is improving, their oxygen saturation is improving, their mental status is improving if I'm doing manual ventilations. If that's the case, then continue the manual ventilations, and the ventilator can be addressed later. If you go to ventilate the patient and the breaths do not go in easily, that's a really good clue that the problem is with your patient. You've removed the ventilator and the potential for that, and you're still having difficulties. And that's when you start thinking, this could be bronchoconstriction, it could be pneumonia, it could be a pneumothorax. And remember all those clues I just talked about. You can, through your patient assessment, you can try to narrow it down and figure out how to treat that patient. So for these patients, if you find out the ventilator is working just fine, you can go ahead and put them back on that ventilator or keep them on the ventilator and bring the vent, if it's portable, with them to the hospital. If it's not functioning, then go ahead and manually ventilate that patient, like I said, and then bring the ventilator with them to the hospital if possible, and they can help troubleshoot it at the hospital. All right, so vascular access devices, this category covers patients who have essentially long-term intravenous devices. So a patient needs long-term IV access for chemotherapy, antibiotics. They might need vascular access for dialysis. That's something we'll talk about as well. So patients get these if they need some way for their venous system to be accessed for more than a week, more than 2 weeks, and sometimes this can be months at a time. And again, that can be for chemotherapy, where patients can go months and months and months and just need multiple treatments and need a real solid place for someone to access their venous system. And then we're also going to talk a little bit about the two types of dialysis. There's peritoneal dialysis and hemodialysis. Peritoneal dialysis being dialysis through the peritoneal cavity in the belly, and then hemodialysis being through the vascular system. And we'll talk about the different ways those are accessed and what types of equipment these patients have. And then patients also might have these access devices for parenteral nutrition, which is IV nutrition, when patients can't take any nutrition via their gut, essentially, and they have to actually have the nutrition put into an IV into their venous system. And then, again, antibiotic administration. And then there's a couple different types of vascular access devices, the two big ones being central venous lines and then implanted ports. The difference is central lines are inserted into veins of the neck, the chest just below the clavicle or the groin, and then the tip of the catheter from there is actually threaded up through the vessel into typically the superior vena cava in the chest. So you have the access point, say it's in the groin, and then the threaded catheter actually goes way up into the body near the heart. And then the peripherally inserted central catheters, which you'll hear referred to as a PICC line, if you look at the first letters, it's just an abbreviation. They're inserted into the arm, and they have that similar catheter that threads up further. There's a variety of brand names. Here's some of them for the different types of central lines that you might see. Patients can have multiple central lines, and then you can see that one central line might have multiple lumens where it can be accessed. What's useful about these in patients is technically ALS can access them in emergencies to administer medication. It's not the go-to. If a medic can establish a peripheral IV, then they'll do that instead of accessing this because of the infection risk, but they are available for access. Another thing you'll see is the implanted port, and this is slightly different. The implanted port is typically in the upper chest, and it's under the skin, but on top of the ribs. And it's vascular access, but there's nothing externally like an IV for you to attach a syringe to. They're actually accessed through the skin with a special needle. And I'll show you the actual device on the next slide to help it make more sense, but essentially you use a special needle and poke it through the skin, and that accesses the port. It's a disc-shaped device, and here's the picture here. So this is the disc-shaped device under the skin. And you can always just ask patients, if you see something like this, what is that? Is that an implanted port? For these, ALS providers will not access these. They require a special needle. They're just, at great risk of infection. And when patients have these, it's very important that they don't get messed up. They need this vascular access. So you won't see ALS trying to access these. Some potential problems that you might encounter with these vascular access devices, these things can clot and potentially become obstructed because of the clot. And then those clots also have the potential to become emboli, causing a pulmonary embolism or potentially a stroke. You can have bleeding around the entry site of the device. These can definitely become infected. That's one of the big risks of these devices, and one of the fears is that they will become infected. They can become dislodged. They can have issues with the actual material where you have cracking of it or of the tubing. If air is some reason injected or enters these, remember it's a direct access to the vascular system, so you can get air emboli, and those can cause strokes. And then a lot of these patients are also on anticoagulation because of this first one here, clots. They need these lines to stay open. And remember, these patients have these catheters that it's not just in the arm. That catheter threads up into a major vessel. So a lot of these patients are on anticoagulants to prevent that clotting. But in turn, that makes them vulnerable to GI bleeds or excessive bleeding from any type of trauma they might experience. So if you see someone with one of these devices, it's always a good question when you're going through their medication list to be very specific and ask, are you on any blood thinners or anticoagulants? When you're taking care of these patients, always look at the site and see, are there any signs of infection? And signs of infection would be redness around the site. Is it tender to touch? Is the skin hot or warm to the touch? And is there purulent discharge coming from the device? As with any other patient, your focus is to correct life-threatening problems. If there's a massive bleed on these, you apply direct pressure. You can put direct pressure on the device, and then if for some reason that's not controllable, you can always certainly apply a tourniquet if possible. And when dealing with these sites, always just make sure you keep them clean, dry, and covered with some type of sterile dressing. Okay, so we'll shift over to AV shunts or arteriovenous shunts and dialysis. This is a kind of a big topic, and this is something you definitely will see. I think most EMS providers go to a lot of calls at dialysis centers. They're just really common, and these patients can be pretty sick. So patients end up on dialysis, and they end up with these AV shunts and some of the things that we'll talk about because of renal failure. And remember, you can have renal failure or kidney failure that is acute, which means it's quick, or it's chronic, which means might have a slow onset and the damage is permanent. The acute can sometimes be fully reversible, but it can also just become chronic kidney failure. This slide just summarizes the three categories of renal failure. When you're thinking about the causes, the general category of pre-renal just means that something before the kidney is causing the issue. Most often this is because of a sudden and severe drop in blood pressure, and that reduces the perfusion of the kidney and the blood flow to the kidney, and that can injure the kidney. Intrarenal means it's intra-kidney, so it's something within the kidney has gone wrong. Something has directly damaged the kidney. It can be anything from toxins, medications, inflammation, infections. And then post-renal means something after the kidney has gone wrong and is damaging the kidney. So obstruction after the kidney, so in the ureters, in the bladder, in the urethra. Any obstruction beyond the kidney can cause a backup of urine and then in turn damage the kidney. And that can be due to, an enlarged prostate is an obstruction, kidney stones are obstructions, any tumors blocking any of these pathways, or injury to the anatomy. And then what happens is in these patients with kidney failure, one of the important things to ask is, do you produce urine? And some of these patients produce no urine, and they're completely dependent on dialysis. So that's always a useful thing to ask. And these patients have a lot of difficulties with their electrolytes, potassium being a big problem, and then a lot of issues with their fluid balance. So they can have a lot of edema. And sometimes they can look kind of similar to a heart failure patient. They can have fluid overload. Now, this is kind of a busy slide of all the different possible causes of kidney failure. All of these things on the side can result in the same end product of renal failure. And I think we talked about most of these, but thrombus, so any clots blocking blood supply to your kidneys. Diabetes is a big one for chronic renal failure. Infections, that's intrarenal. A lot of hereditary and genetic diseases can cause kidney problems. Exposures to toxins, smoking, and then obesity. This is just a picture of, so here's a normal kidney, and here's two kidneys that are kind of shriveled up and discolored from chronic renal failure. So these patients are dependent on dialysis. As the kidney failure worsens, they'll go from, some patients will say, I just get dialysis twice a week. So that's a really good question to ask these patients. How often do you get dialysis, and did you miss dialysis? Some patients need it every day, so just depending on how severe it is, that will be really variable. And dialysis it's a procedure, and this is the dialysis machine, and here's this patient's access point. And it removes water and it removes waste products. So the dialysis machine does the job of the kidneys. And remember, some of these patients produce minimal urine and sometimes no urine. They really can't get rid of any of their fluid, and they can't get rid of their waste products. And there's two big types of dialysis. There's hemodialysis, meaning it's like directly into the vessels in the blood. And there's peritoneal dialysis, meaning the dialysis is in the peritoneal cavity in the belly. And both of these work through osmosis and filtration of fluid across some type of semi-permeable membrane, and often use something called dialysate. This patient is in a dialysis center, and you'll often be called to the dialysis center. And patients go to these centers whenever they need dialysis, and there's long rows of chairs and just multiple patients getting dialysis at the same time. Often it's 3 days per week. It can be less or more frequent. It takes a good chunk of time. It's 3 to 4 hours at a time they have to be hooked up to the machine, and their blood is extracted and sent through the machine here and then returned. And the dialyzer is the dialysis machine. It removes the toxins and fluids and then returns the blood back to the patient. And it requires a really good access point to get blood. You can't just start IVs and do dialysis on these patients. So we'll talk about the different types of ports people have. One type you can have is a dialysis catheter. These are more temporary. This is when a patient, urgently needs dialysis, and a dialysis catheter is put in place as a temporary, meaning, probably weeks they'll keep this to have a temporary access point. And these are placed often in the upper chest, the neck, or in the groin, and the tube travels under the skin and into a vein and into the heart. Here's the access points here, the ports, and there's usually two that are accessed. One is a venous port and one is arterial port. One's for blood going into the body and one's for blood coming out of the body. I like these pictures. These are the different types of accesses you'll see for dialysis. So this is a fistula, which means that the fistula is where the patient's vein is surgically connected to an artery. right here. And then this is an AV shunt, arteriovenous shunt. And there's a graft here that's external that attaches a vein to an artery. And then this is the catheter, the temporary one I was talking about. And this is a graft here where the artery is attached to the vein. And these grafts, this one is internal. And then this is the external AV shunt. So the AV shunt, this one is also more short term than the fistula. So one of the most long term, the best long term versions here is the fistula, and the AV shunt is one of the short term options, usually 6 months or less. And this is 2 pieces of tubing. They're connected here externally. So one is connected to an artery, one is connected to a vein, and then they connect to each other externally. And then during dialysis, they're detached from each other, and then you have 2 access points. So that's one option you might see that patients have. And then the AV graft, this is longer term, and this is some type of artificial blood vessel, or sometimes they can actually take a blood vessel from another part, like from another vessel in the patient, and use that to connect the vessels, which is pretty cool. And what it does is it attaches the artery to the vein. And the reason for this is just so that you can get enough pressure coming from the artery to have an easy access point, a reliable access point that allows enough blood flow and pressure to be able to connect the dialysis machine. And then, let's see. So this down here is the AV graft that we were just talking about. And here's the artificial vessel connecting. And this one is the fistula, where you have the AV anastomosis, just meaning you connected the 2 vessels, connecting the vein to the artery. And then here's the fistula. This is like the ideal setup for a patient to have long term for dialysis, and these are quite common. So in this patient, you have the vein here, and they connect it to the artery here, and it's a pretty big opening between the 2. And the vein is the point where the needle will be inserted, and what will be accessed during dialysis. And these can be used for years at a time, and they take time to mature. So when the patient goes to the OR and gets this fistula, it takes like 3 to 7 weeks for the vein to slowly enlarge and for the walls of the vein to thicken. Because remember, the vein's under increased pressure now because it's receiving arterial blood flow. And then after it kind of thickens and enlarges, it can withstand the repeat needle sticks that you need to have dialysis treatment. And then you can use it for years thereafter. So we're really asking a vein to function kind of like an artery, which is super interesting, but it works pretty well for this. The pros being that this is a long-term reasonable method. It has lower rates of infection. Some of those other ones where you're inserting artificial grafts and things like that into the arm have a higher risk of infection because there's no foreign body here in this fistula. The downside being this does take time to mature, and they can't just get this quickly. So this is what the fistula actually looks like after it's matured on a patient. This is the vein. And you can, if you put your hand over this and you feel it, or you take a stethoscope and listen to it, they kind of have a loud hum because all that arterial pressure is coming through that vein. And then what they do in dialysis is they'll put the needle right into here and access that vein. And these they look like this. They're very irregular, very unnatural appearing, and you should recognize them as a fistula. And if you see, this is why it's so important to pay attention to where you're putting the blood pressure cuff, because you cannot and should not take a blood pressure on a patient with any type of vascular access device, fistula, anything on that extremity. So if you hear a patient has kidney failure or they're at a dialysis center, ask them, where is your fistula? Where's your catheter? can I take a blood pressure on this arm? And don't ever take the blood pressure on the arm with the catheter or fistula. It's just because the anatomy underneath the skin has been altered surgically, and if you apply pressure from that blood pressure cuff, you can disrupt the fistula, and you can actually cause irreparable damage and cause the patient to have to go back and get some other type of vascular access. So when you go to these dialysis centers, you can be called for a variety of things. Some of the more common potential complications are related to the fluid shifts during dialysis. And so one potential problem you can get is hypotension or low blood pressure, where I remember many calls where we would go because patients had experienced syncope, they had passed out or were dizzy. Patients can get muscle cramps. They're having a lot of electrolyte shifts during dialysis. And those electrolyte shifts can cause muscle cramping. Peritonitis, inflammation of the abdominal cavity, which will make a little bit more sense when we talk about peritoneal dialysis. These patients can have a lot of nausea and vomiting. It just comes with the dialysis. It can make them pretty sick at times. You can have hemorrhage at the vascular access site, and that can be pretty scary because remember, you're connecting veins to arteries, so these can be very swift arterial bleeds. Infection can happen. That's why it's always important to look at the site for redness, for swelling, for purulence. And then these patients can have cardiac problems. They might have an irregular heart rate, irregular pulse. They could be in cardiac arrest. And a lot of that has to do with the fluid shifts and also the electrolyte imbalances. And then these patients can also have difficulty breathing. Remember, these patients can have edema. They can look kind of like heart failure patients. So they can have respiratory problems as well. In people's homes, I remember a lot being called to patients where they were feeling generally unwell or sick. And this is why it's so important to ask about their medical history when they say, I'm on dialysis. And that's why you should ask, how often do you get dialysis? What type of dialysis do you get? And have you missed any treatments? Because missing dialysis is not a small thing. These patients need dialysis. If they don't get dialysis for a prolonged period of time, it will be fatal. Missing 1 or 2 sessions, might not cause significant problems, but it can. They'll become very weak. They can have pulmonary edema because they're starting to get fluid overload because they can't clear out their water. They can have cardiac dysrhythmias. And remember, that's because of they can't get rid of their electrolytes either. They're not peeing normally. Their kidneys aren't filtering out their electrolytes, and potassium is a big problem for these patients, and that can cause them to have arrhythmias. And they might just generally feel sick. They can just feel very tired and very sick after missing dialysis. And if these patients, present to you and they've missed dialysis, you should transport them to the hospital, and they can get dialysis in the hospital and treatment for whatever else is going on. So peritoneal dialysis, this was, remember, one of the 2 options. You have hemodialysis and then peritoneal dialysis. And this one is dialysis through the abdominal cavity. What's kind of cool about this one is patients can do this in their own home, so they don't have to constantly drive back and forth to a dialysis center. There's a lot of limitations to why people can't have this, because it sounds ideal. Like, why doesn't everyone get peritoneal dialysis? But the patients still have to be producing urine to get this. So if the patients aren't urinating at all, this is not an option. And then they can't be super, super sick with kidney disease. This is something that usually patients get earlier on in the kidney disease. But patients can do this at home. And what it basically is you have the solution at home, the dialysis solution or the dialysate, and it's put into the peritoneal cavity here, and you leave it in for like 3 to 5 hours, and it interacts with the peritoneal cavity, and the fluid directly surrounds the intestines, and it kind of works with the body to help absorb the waste products. And then after the 3 to 5 hours, the patient removes that fluid from the peritoneal cavity and takes note of how much fluid is removed. And then here you can see that, it's variable, but this process often needs to be done multiple times a day. So the catheter is, there's a catheter in the abdominal cavity, and then there's a catheter outside where it's accessed by the patient. And the catheter permanently remains in place. So the patient's not sticking themselves multiple times a day. They're just accessing a catheter that's in place. And one of the problems with dialysis that I mentioned earlier is peritonitis and infection. And it's an unnatural opening to the abdominal cavity. So these patients are prone to infection within the abdominal cavity and then inflammation of the peritoneal lining, which is peritonitis. So that they'll present with, maybe fevers, generally feeling unwell, tired. Their abdomen will be very tender because their whole abdominal wall will get inflamed. These catheters can also become blocked and inaccessible, which means they need to go to the hospital and someone has to establish another form of access. If there's kinking of the catheter internally, then they can't pass the fluid. They can also become hypotensive or hypovolemic, similarly to the dialysis patients. So some of the complications and emergencies that you'll have to deal with for hemodialysis, the patient's going to have direct complications of the dialysis, so issues with catheter, bleeding around their access point, bleeding around the shunt. It can become infected or it can become clotted. Bleeding is, we'll talk about how to address these, but bleeding is a big concern. Additionally, these patients can get sick with other things while they're having dialysis. So don't think just because you're going to a dialysis center that the problem is going to be with the dialysis. I've responded to heart attacks, cardiac arrest at the dialysis center. So other things could be going on even though they're getting dialysis. And then peritoneal dialysis, like I said, the big issues are infection, displacement of the catheter, kinking of the catheter, and then inflammation or pain at the insertion site. The emergencies with peritoneal dialysis are not typically quite as emergent and severe as hemodialysis. Usually more long-term. Infection is not quite as acute, and kinking of the catheter is just an issue that needs to be addressed, but it's not immediately life-threatening. So when you go to these dialysis centers, the staff are your friends. They know the machine, they know everything going on with that patient, how much fluid they've removed, how long they've been on dialysis, their vitals while they've been having dialysis. So you should ask the dialysis team to go ahead and remove the patient from the machine. Not something you should be doing. It needs to be done very cautiously because they can't just remove them at any point. They have to make sure they don't cause massive fluid shifts or volume depletion. And then ask the staff. A lot of these patients will have clamps on their arm for bleeding after they remove the catheter. Ask about, do I leave that? Are you going to take that off? Just be clear that you know what is on the patient and what to do with it. If they're having a massive hemorrhage, it's the standard hemorrhage control. Place a gloved hand, direct pressure on the site of the bleed. Even if it's on the fistula and it looks like a weird place to apply pressure, just put direct pressure on the bleed. Sometimes that won't control these bleeds because remember these can be arterial bleeds because the veins are often connected to the arteries. So if you need to place a tourniquet because your direct pressure is not working, go ahead and place the tourniquet. And then treat these patients for hemorrhagic shock if it's reached that point, giving high flow oxygen and keeping them warm. If the patient is having chest pain, use your standard protocol. If they meet the criteria for nitro, just pay particular attention to their blood pressure in these patients. It can be quite precarious. And then aspirin if indicated. And then definitely call for ALS backup if you have an emergency with these patients. Like I said, this is a very common thing you'll deal with. EMS goes to many, many calls at dialysis centers and then also at home for complications related to kidney failure and dialysis. Shift over to GI and GU devices, so gastrointestinal and genitourinary. We'll start off with the gastrostomy or the feeding tube. The feeding tube, so these are named, some of these names can get kind of complicated, but they're nicely anatomically named. So the gastrostomy tube just means it goes directly into the stomach. And then other tubes you might see be a nasogastric, which means naso, through the nose into the stomach. So the tube goes into the patient's nose and down to their stomach for feeding. The orogastric tube, pretty intuitive, into the mouth, down to the stomach. And the gastrostomy tube, like I said, is straight into the stomach through the skin, also called a PEG tube. All of these serve largely the same purpose, just to feed the patient and provide nutrition while bypassing having to actually eat, chew, swallow food through the mouth. The reason the patients get these can be quite variable. It could be because they can't chew, maybe they can't swallow, and that can be due to a number of medical illnesses, trauma. They might have some type of paralysis. They might be unconscious. Or they can just have issues with their upper digestive tract. So there's a lot of reasons patients have these. But when you're referring to patients who have these types of feeding tubes, it's referred to as enteral feeding. It's also commonly called tube feeding. And the tubes that are in these patients are pretty long but flexible tubes. They go into the stomach, and then you just pump the food. It's usually a liquid kind of smoothie type mixture through the tube and into the stomach. So the gastrostomy tube, here's an example here. That's what it looks like. And, this port is always present. And then the patient can hook up the tubing here to the food during the day. And sometimes, this is over a period of hours. They need to be attached. Sometimes it's less to go ahead and give them nutrition. So again, it's, patients who can't take things by mouth, a lot of chronic diseases, central nervous system disorders that prohibit the patient from, they can't swallow, they can't chew. It can be from, strokes. It can be from things that patients are born with. And then some patients, you might see this in the younger kiddos. They're just developmentally hindered, and they weren't able to develop properly to be able to swallow food. And then, of course, patients that are comatose can't eat. So this is an option for feeding them as well. Sometimes in kids, some kids they can have metabolic disorders as well, where they just can't process nutrients correctly. And some of them need supplementation with feeding tubes. And then, let's see, the only other thing, developmentally hindered, I'll say another cause for that would be sometimes kids can have something called short bowel syndrome, so they just don't have all of their intestines, and they can also require this type of feeding. So the issues you can run into with these gastrostomy tubes is that because it's a direct route externally into the stomach, they can certainly become infected. So remember, you're looking for that redness, swelling, and purulence, and tenderness. They can become dislodged, so potentially you can have damage internally or externally that can be bleeding. And then you can also, if the entry point is disrupted, you can have leakage of the formula around the site, and that will also lead to irritation, inflammation, and infection. I think one of the most important things to say about these three different types of feeding tubes is just ask the patient if you're not sure. And the same as we go, well, really for any of these special populations, is just be honest and say, I'm not familiar with this. And they know that, sometimes what they have is not very common. And say, could you please explain to me, where does this attach? What does this do? Have you had problems with it before? And a lot of times these patients are the masters of information with their illness and can really help you help them. Ostomy bags. So remember they're named anatomically. So these are collect fecal matter and are directly connected to the intestine. So here's some good diagrams. There's a variety of places. It's an opening from the outside and then directly to the intestine. So surgically, what these patients have is the surgeon goes in and cuts a hole somewhere in their intestine, and it literally attaches the opening of the intestine to the outside. And it's kind of, it looks super red, super pink, and you're actually seeing part of the intestine. And then a bag is attached to the outside, and then the fecal matter just drains to the outside. And so you'll hear people refer to these as different things. They might say, "Oh, I have a sigmoid colostomy." I have a double barrel colostomy, or they might just say, "I have a colostomy bag." So the sigmoid colostomy, these are all named anatomically. It attaches the little pink donut thing there. That's the opening where the bag would attach to the outside. So the sigmoid colostomy just means it's in the sigmoid colon, which is this portion here. The descending colostomy is in the descending portion. Transverse is in the transverse section here. Transverse double barrel is here. This one's interesting. There's actually two openings to the outside. The fecal matter comes from this side, and then the remainder of the colon isn't attached for fecal matter to pass through, but it still drains a lot of mucus and byproducts that need to drain into a bag. And then the transverse loop colostomy is pretty similar to the transverse single barrel. Some patients will have these on a temporary basis. They may have had some temporary state or temporary surgery that eventually might heal, and they can actually have their intestines reattached, and they can have a normal GI tract. So they might have this for months at a time, and then some patients have permanent colostomy bags. And these bags need to be they need to be kept clean around the entry point, and then they also need to be emptied multiple times a day. Some examples of reasons patients would have these: patients with Crohn's disease, when they have portions of their intestines removed. Ulcerative colitis is another inflammatory bowel disease. Colon cancer, patients might have to have part of their intestine surgically removed. Same for diverticulitis. And then any trauma to the bowels. If patients have gunshot wounds or stabbings, they might have to have parts of their bowel surgically removed and get a colostomy bag. For urinary tract devices, these are very, very common, and a lot of patients will tell you, I have a urinary catheter, and this can be a big source of infection. So that's quite often that's why you're seeing these patients, is they have infections. But the urinary catheter diverts urine out of the bladder when there's some type of dysfunction along the urinary tract. And there's a few different types of these, but here's just a picture of the external bag, and the urine drains into a bag and then is emptied from there. So let's see, the most common one you're going to see is the Foley catheter, and this is the Foley catheter here. And the Foley catheter inserts externally through the urethra in both the male and the female. And then this tube here is what goes up into the bladder. And then the end of that tube sits in the bladder to collect urine, and a balloon inflates in the bladder to keep it from coming out. It's kind of like an ET tube where you inflate the balloon and it holds it in place. And then the urine drains out this tube and into, you can't see the connection here, but into this tube, and then it drains into the bag. And the biggest complication with this is definitely urinary tract infection. It's a foreign body in the urinary pathway, and then if that's not treated, that can eventually lead to sepsis and shock. And then this this catheter here is called a Texas catheter. Most commonly, you're going to hear people refer to as a condom cath, and this is less invasive, and it just goes over. It's for males. Only males can use this condom cath, and then there's the female version here. The male version goes on just like a condom, and it collects urine into a bag. It's less invasive, and it's good for patients who are bedridden, who can't get out of bed to urinate, can't use the bedpan well, but it can cause a lot of external irritation, but they're good for short-term use. And then this is the female version here that's placed externally, and soaks up urine in a similar way, but not quite as ideal for the female patient. And then a urostomy, there's two more permanent forms to collect urine, the urostomy and the suprapubic catheter. The urostomy creates an opening or a stoma, and the catheter is not in the bladder. It actually connects directly to the ureters. And remember, the ureters are what drain the urine from the kidneys into the bladder. So this collects urine above the bladder. So this is for patients who have an issue. Maybe they can't have a catheter in their bladder, so you have to go higher up, and it collects urine from there. Now, the suprapubic catheter has a catheter where it goes in through the skin. Here's the suprapubic over here. And it's above the pubic bone. That's why it's suprapubic. Here's the pubic bone. And it goes straight into the bladder. And then similarly, there's a little balloon inflated in the bladder that holds it in place. And both of these will do the same thing where you drain the urine into a urinary a bag externally. And then here's the picture of the urethral catheter I was talking about, which is also the Foley catheter. It goes in through the external genitalia and through the urethra and goes up into the bladder. So patients with these GI or GU devices are all prone to infection. No matter which one they have, pretty much all of those can get infected. So you're always asking about symptoms. Are you tired, fatigued, do you have fever? Are you urinating normally? Are you using the bathroom normally? Do you have diarrhea? Do you have constipation? Are you producing urine? Is there a foul odor to your urine? Is the urine the normal color? Things like that to try to kind of tease out if they're having infection. And then all these devices can malfunction, and that's one important reason they need to be transported and evaluated. They can become misplaced or obstructed. And your care for these patients is the same as for all patients. Addressing life threats, evaluating your ABCs, and collecting your history and completing your physical. I think the most important thing is just to make sure you understand what's going on with the patient. Where does that opening lead? Where does that catheter go? What kinds of problems have they had in the past? And being conscientious when handling this stuff to make sure you're not dislodging their catheters. Ask them, do you need to empty the bag if it's full? Do we need to empty that before we go? And with the urinary catheter, keeping the bag below the level of the patient. You don't want to pick up the urinary bag or the ostomy bag full of, urine or feces above the patient, have it drain back into the patient. Being mindful of that. I think especially for the urinary bags, making sure you take a look at the urine and see what color it is. Is it pink? Is it red? Does it have blood in it? Is it chunky? Is it look infected? And making sure it's not overflowing and doesn't need to be drained before you transport. And then keeping both those bags below the level of the patient so it drains properly. All right, so our next thing is intraventricular shunts. An intraventricular shunt is it's intraventricular, which means it's within the ventricles where there's cerebrospinal fluid in the brain. And it's a shunt, meaning it's shunting fluid, the CSF, from that space to somewhere else to drain. And quite often it goes into the peritoneal cavity where you drain that fluid. So when that's the case, they're called ventriculoperitoneal shunt. So ventriculo from here, from the ventricles to the peritoneal cavity. And the reason for this is for when patients are unable to drain their own cerebrospinal fluid out of their brain. And this allows essentially an escape for that fluid to be absorbed elsewhere. And the problem is, remember, the head is a closed space. So if patients can't drain their own CSF and reabsorb it, they're going to have increased intracranial pressure, and that can eventually lead to death. It's very common in pediatric patients. is probably mostly who you'll see these shunts in, but you can also see them in adults who've had head injuries, traumatic head injuries, or hemorrhagic strokes, and their brain, just because of the new anatomy and the damage, can't reabsorb the CSF properly, so they also need these. Like I said, typically it goes into the peritoneal cavity to drain. So what you'll see on these patients, this is not external, this is internal. So you might see the tubing running underneath the skin, but and maybe you might see on the back of the head a protruding mass underneath the skin, but this is all internal, so you can't see the drain on these patients necessarily. So that's something you're going to have to ask and be like, tell me about the shunt. And the patients will know that there's a lot of shunt complications with these. They're usually pretty well educated. So the potential complications, one is an infection, and that's super important because this is in the patient's brain. So you have to be on the lookout for any signs of infection. Shunt occlusion, meaning there's a blockage somewhere in that shunt, and that can be anywhere from where it's inserted into the ventricles in the brain all the way down to the peritoneal cavity. And then subdural bleeding, which is because, remember, this has to exit the brain. So if you get bleeding in there, you can have a subdural head bleed. So an infection in these patients, like any infection, take time to develop. So patients will often describe a gradual decline in their health where they say, I've been really tired, and they may have had some fever or chills. They might have a headache. They might have local signs of infection, and it's important that you ask, have you been tired? Have you been eating? And things like that. And then bleeding is always possible, especially the subdural bleed is concerning, and that can also be a slow bleed as well. So they might have slow confusion, be more somnolent or tired, and that can be progressive. And then the occlusion, this is like the big scary complication of these things, because if they have an occlusion, they can't drain the CSF, and they'll have slowly increasing intracranial pressure. And these patients present very similarly to any patient with a traumatic head injury or a massive stroke. They can have headache, they can be dizzy, they have the nausea from the increased intracranial pressure, they can be very weak. As it progresses, they can start vomiting, they'll become altered, their mental status will be very poor, they can have sensory or motor dysfunction, kind of like strokes, they can have seizures, and then late in the process, they can have respiratory depression and death. So your job for these patients is to, obviously assess them and then support whatever loss of function they might have. If that's their airway, then you can provide positive pressure ventilation or oxygen supplementation. And then importantly, you just want to rapidly transport these patients, and you can do that in a lateral recumbent position. Sometimes if these patients are super sick by the time you get to them, they might have lost their respiratory drive. So that's why airway is so important in these patients too, is you might have to go ahead and put them on the BVM and give them supplemental oxygen. So just some additional considerations for these patients. A lot of, all the things we talked about today, the equipment can be very intimidating. There's so many different brands of the different equipment. There's so many different variations. And that can be pretty intimidating. I think that's why it's so important if the patient knows anything about the equipment, just ask them, where does this go? How does this work? And they typically are very understanding and want to share information with you. And then these patients also sometimes can't communicate effectively, which makes it very difficult to care for them. It's super helpful if they have a care provider you can talk to, or if they have a family member there. Remember, some of these patients, like patients on vents, have alternate modes of communication. I remember one patient with ALS that was in their home, and they had a communication board, and the family helped us communicate and ask the patient questions. And sometimes patients can nod, they can use their eyes to communicate. So just because they can't talk, remember that they might still mentally and cognitively be very aware. So make every effort to communicate however they need communication. And then some EMS agencies have really good records of patients in the community with very special needs. Some of these patients, their family or they will reach out before they have a medical emergency and ask for providers to come by to explain what their needs are. So these home visits can be super helpful. All right, so let's work through one final case presentation. So you're dispatched to a private residence for just some unknown emergency. And you're directed to a 68-year-old female that's in her bedroom, and she's supine in a hospital bed in her bedroom. And when you walk in, you see that she is she's on a ventilator, and you hear a loud beeping coming from the ventilator that's at the bedside. And you look at the ventilator, and it's attached to a tracheostomy tube that's in her trachea. You introduce yourself, and you try to get the patient to respond to verbal stimulation, as she's not alert. You can hear from where you're standing next to the bed that you can hear crackling sounds of mucus and congestion coming from around the ventilator circuit. And this can be pretty noisy. It's kind of like gurgly, raspy noise. You can hear it. And then you look at the ventilator, and the red light that's illuminated says high pressure alarm. And then the family on scene is very distressed, and they say, the patient just got home from the hospital yesterday. And this is kind of a scary situation, because what that says to me is the family's not familiar with this equipment yet, and everything's as new for them as it is for you. So that can be kind of problematic, and they're going to rely pretty heavily on your knowledge. You find out the patient was in the hospital because of a massive stroke and was placed on a ventilator in the hospital. And the family brought her home so they could provide ongoing care instead of a nursing facility. But again, the family isn't really familiar with the ventilator, and they're quite panicked because they don't understand the alarm. So the first question, what emergency care would you provide during the primary assessment? So for your primary assessment, you want to go ahead and make sure you've taken standard precautions and look at the patient, observe what you're seeing, and go ahead and temporarily detach the ventilator. And because you're already hearing secretions and you see a high pressure alarm, you can put 2 and 2 together and say, all right, I need to suction out these secretions or the mucus from the tracheostomy tube. So you go ahead and do that. And then you provide positive pressure ventilation via the bag valve mask and see if you meet a lot of resistance. And you want to use high flow, high concentration oxygen until you can go ahead and make sure the airway is secure. And then if you're able to clear the secretions and you can bag the patient and you don't get much resistance, you get good chest rise and chest fall, and the condition of the patient is improving, you can reconnect the patient to the ventilator. The second question is, based on the signs, what condition do you suspect the patient is experiencing? Kind of gave that one away, but we have a high pressure alarm and you're hearing a lot of gunk in the tracheostomy tube. So you should be thinking this patient probably has an occlusion. The machine is saying, I'm having to push a lot of pressure into the tracheostomy tube to get the amount of air in that the machine wants to get in. So that's a high pressure alarm. And then you're hearing those noises, so that's a good clue that there's an occlusion. Number 3, what in your opinion is causing the ventilator to alarm? Again, it's the high pressure alarm is due to the resistance detected by the machine from the airway occlusion. Number 4, what type of care would you provide to this patient to support lost function? So you have to remember why the patient's on the ventilator, and this particular patient is probably on the ventilator, one, from the brain injury due to the stroke, so they're not able to breathe adequately for themselves. So they're dependent on this machine to give them the tidal volume they need with each respiration, and they're continuously supported by that machine. So if you disconnect them from the ventilator, you have to make sure you're ready to bag the patient. You can't just put a non-rebreather over their tracheostomy, or you can't just put a little bit of oxygen in there. You need to provide mechanical ventilation to make sure that they're getting properly oxygenated. Number 5, should this patient be transported to the hospital, and if so, why? For this particular patient, if you suction them and you say, wow, yeah, there was a big glob of mucus right in the tracheostomy tube and their condition improved and there's no more high flow alarms and everything's settled out, they don't necessarily need to go to the hospital because you did fix the problem. But I think even if it seems like you've completely fixed the problem, I would still go ahead and contact medical direction, discuss the pros and cons of this decision. they might have a little more knowledge about the underlying problem, and they might say, well, what's causing those increased secretions? Why did they have the mucus plug? And they might have more concerns about the patient and think they need to be transported. And then there's also things you can explore to help the patient care for the family care for the patient. You might be able to talk to medical direction about, is there someone more in-home nursing that can come help this patient? Or ask the family, do you have in-home nursing available that can come out to help you troubleshoot this in the future? So a lot of times you'll need to transport these patients. Sometimes you won't, but you can always reach out to medical direction and get their opinion. That's it for the lecture. Thanks, guys.